we are going to talk about a topic that often inspires terror. And that topic is acid-base disorders and ABG analysis, okay? Disclosures, I have no actual or potential conflict of interest in relation to this topic, okay? And here's what we're going to do, okay? We're going to have some simple goals. This is not meant to be an absolutely comprehensive lecture about ABG analysis. What I intend here is to give you the tools that will allow you to quickly, consistently, and confidently analyze acid-base disorders, okay? What you need to know to start is that acid-base disorders are commonly seen in critically ill patients. They can range from obvious to subtle. This is an area of confusion and misunderstanding, and I do not want you to be intimidated, because a triple acid-base disorder can be solved in about 30 seconds if you do the 6 steps that I will give you. And you will get it right every time, and you will never get it wrong. Okay? That's my promise. So in general, we're going to start with the rule of homeostasis, which simply expressed is in equals out, or you die. Okay? To put it simply from an acid-base perspective, that's your picture. Okay? If you can't read it, the jar is sulfuric acid. All right, so let's start with some terminology. So who wants to tell me what you call a pH of 6.9? Okay, so I have a vote for acidosis. What else? Are there any other suggestions? Because I can tell you that that's the wrong answer. Okay, well that's another good answer. Acidemia! Okay, so I will tell you that a person with a pH of 6.9 certainly has an acidosis. But when you refer to the pH of 6.9, you don't call that an acidosis, you call it an acidemia. The concept here is that emia and osis are not the same thing. Emia is the state. Osis is the process that drives the state. So when you refer to pH, because I'm a purist, you should use the term acidemia or alkalemia. When you refer to the process that is driving that pH, then you can use the term acidosis or alkalosis. Okay, so to be simple, an acidemia is a state in which the blood pH is less than 7.4. Alkalemia is a state in which the blood pH is greater than 7.4. The acidosis is the process that produces the acidemia, and the alkalosis is the process which produces an alkalemia. Okay? So, if we know this, and we want to avoid the goldfish being upside down, okay, what are some mechanisms of acid-base homeostasis? How does the body maintain a normal pH? Okay, by metabolic and pulmonary compensation. Are there other ways? Well, we'll consider that the metabolic compensation. So here they are. Dilution is the solution to pollution. If you took that bottle of sulfuric acid and poured it into the goldfish tank, the goldfish would die. But if you poured it into the Hudson River, nothing would happen. Probably because the Hudson River is already very acidemic. Okay? But dilution is the solution to pollution, and in the extracellular fluid, we have the ability for there to be a dilutional effect. There's also buffering capacity that happens extracellularly and intracellularly, but metabolic and pulmonary compensation is a big part of this, okay? To be very simple, lungs, respiratory kind of thing, okay? They blow off CO2. CO2 is an acid. The lungs have the ability to modulate the acid content in the body. Kidneys, metabolic thing. They have the ability to modulate bicarb. Bicarb is a base. So the kidneys have the ability to modulate how much base you have. So lungs, respiratory, acid. Kidneys, metabolic, base. So if the respiratory rate goes down, the PaCO2 goes up, what happens to your pH? It goes down. All right, so that will create a respiratory acidosis. Okay? If the respiratory rate goes up and you blow off more CO2, that's going to create a respiratory alk. Similar concept with the kidneys. If bicarb reabsorption goes down and your bicarb goes down, that's going to create a metabolic acidosis. If it goes in the other direction, you're going to get a metabolic alk. You following me so far? I know this is basic, but we're going to start basic. So, acid-base disorders live on a continuum from we're all good to things are really, really bad. Like you said, that pH of 6.9 is not compatible with life. Not for a long period of time it isn't, and you can get an upside-down goldfish. Okay, so here we go. Some terminology. The primary process, okay? Every acid-base disorder has a primary process, and that process is the process that is primarily responsible for driving the pH, okay? A primary process can only be partially compensated for, okay? Compensation can never completely overcome the primary process, okay? The primary process is almost always evident from the pH and from an analysis of what the PaCO2 and the bicarb are, okay? Super important, okay? Concurrent process. You can have 1, 2, or 3 processes that occur together. One of those, and only one of those, gets to be the primary process. The others we're either going to call concurrent or compensatory. So you can have a metabolic acidosis and a metabolic alkalosis at the same time. Give me an example of how that could happen. Say that again? Well, aspirin will give you a respiratory and a metabolic process at the same time. How about, yeah, the famous nausea, vomiting, diarrhea, okay? So in vomit, you lose what? Hydrogen, acid. And in diarrhea, you lose what? Bicarb, base. So in somebody who comes in with nausea, vomiting, and diarrhea, you can have a metabolic acidosis and a metabolic alkalosis at the same time. You cannot have both a respiratory acidosis and a respiratory alkalosis at the same time. You do not have the ability to breathe slow out of one lung and fast out of the other. It's either one or the other, either over or under ventilating. So you can have a triple acid-base disorder because you can have 2 metabolic processes and a respiratory. Okay, let's talk compensation. Every process will elicit a compensatory process. The respiratory system will attempt to compensate for metabolic processes. Conversely, the metabolic system will attempt to compensate for primary respiratory processes. Compensation will never reach total correction, nor can there be overcompensation. You need to know that for when you start to analyze things. Okay. In respiratory compensation, you can either breathe fast or breathe slow, okay? But you can only do it so much. The lungs will do this very, very quickly, but their ability to compensate is limited. A patient cannot hypoventilate beyond a PaCO2 of 55 to 60. They just cannot do it. Similarly, they cannot hyperventilate beyond a PaCO2 of 12 to 14. Not possible. Because of that, there is a limit to how much the lungs can compensate for a metabolic process. Conversely, okay, the kidneys can compensate for primary respiratory processes by adjusting bicarb reabsorption, okay? This does not happen immediately. However, they're really good at it. And relatively speaking, they are better than the lungs at compensation, okay? So metabolic compensation for an acute process is minimal because it takes a while. But for a chronic process, okay, the kidneys can actually drive the pH to near normal levels. They'll never get it all the way there, but they can get close. And this makes your life a little harder because now there are 2 formulas for calculating the appropriate metabolic compensation for a respiratory process. So you with me so far? Okay. We're being simple. There are 4 primary processes, okay? Metabolic acidosis and alkalosis, respiratory acidosis and alkalosis. We're going to bang through these quickly because I got to get to the good stuff. So what's a metabolic acidosis? A decrease in bicarb with a subsequent decrease in pH. How does this work? You have too much acid production or you have decreased bicarb reabsorption. How do you address this? You treat the cause, okay? For now, you should know that there are 2 flavors of metabolic acidosis. There's anion gap metabolic acidoses and there are non-gap metabolic acidoses, and we will talk more about that later. Metabolic alk, well, there's more bicarb, and consequently there's an increase in pH. And how does this work? You lose acid or you add alkali, okay? And there will be some enhanced renal reabsorption of bicarb. You have to have both and you treat the cause, okay? When you talk about metabolic alkalosis, it is often useful to differentiate between saline responsive and saline resistant. And I don't want to go into the details of that right now because, as I said, this is designed to be practical and not comprehensive. What you should know about metabolic alkalosis is the two common causes are volume depletion, okay? Another word for that is a contraction alkalosis, and GI losses, okay, from vomiting or an NG tube. Here's a chart that tells you the common saline responsive and saline resistant ones, and you should read about this. Treatment for both is volume. If it's saline resistant, you need to give some chloride also. I know I'm just blowing through this, but we got to get to the good stuff. Respiratory acidosis, an elevation in PaCO2 with a subsequent increase in pH. Why does this work? Because for some reason there's a decrease in the rate of alveolar ventilation. It can be acute, chronic, you treat per the cause. Here's a list of the things that can cause you an acute respiratory acidosis. This is not a comprehensive list, there's a lot of others. Here's some chronics, okay? Respiratory alk, you breathe faster. There's a lot of different causes. You treat the cause. Here's a list of causes. Mixed disturbances, okay? In a mixed disturbance, there's more than one process. Only one of those processes gets to be the primary disorder. The other ones are concurrent or compensatory. Triple acid-base disorders are not rare. I guarantee you that you will see a lot of these if you look for them. And I guarantee you that if you haven't been looking for them, your patients have had them, okay? So, now we're going to get to acid-base analysis. Don't do that, okay? Instead, don't panic. Be systematic. Follow the same 6 steps every time. Recognize patterns. Don't memorize too much stuff. And probably the most important thing is you need to correlate your acid-base analysis with the clinical situation. Otherwise, you did a whole bunch of fancy math and you didn't apply it. Okay. So we can understand acid-base disorders by getting an ABG, by getting a basic metabolic panel, and by having the ability to add and subtract. Okay? Little clinical pearl. If you draw the ABG at a different time than you draw the chemistries, you will be wrong, okay? You have to get both simultaneously, or if it's not possible to get them exactly simultaneously, as close together as possible. Otherwise, you're going to be apples and oranging. Okay. Here are the components of the ABG. There's pH, there's PaCO2, there's PaO2, there's bicarb, there's O2 sat, and there's other stuff, okay? We will not be discussing base deficit in this lecture, okay? Okay. For the purpose of this lecture, and what I suggest is that you eliminate ranges, okay? Other people will not necessarily tell you to do this, but I'm going to tell you to do this. 7.4 is normal, okay? We can tolerate a deviance from 7.4 to the tune of about 0.04 without a lot of trouble. So a lot of references will tell you that a pH of 7.36 to a pH of 7.44 is normal. But I'm going to tell you to use 7.4. Otherwise, when you start looking at this, you're going to be confused. Similarly, we're going to say that a PaCO2 of 40 is normal, a bicarb of 24 is normal, and a gap of 10 is normal. Now, there's a range for that too. And if you look at what actually should be normal, the literature is conflicted about this. A lot of the literature says 12. A lot of the literature says 10. The real answer is it really depends on your patient. Patients will run a little bit lower and run a little bit higher. And if you have the luxury of knowing what a normal gap for your patient is, good for you. But for the purposes of this lecture, use 10. Okay. Key slide. Memorize. Write down. Tattoo. Okay? Use this. These are the 6 steps. Number 1, what's the pH? Number 2, what's the primary process? Number 3, what's the gap? Number 4, what's the delta-delta? If you've never heard of that, you're about to. Okay? Number 5, is the compensation adequate? And number 6, why? Okay? There are other ways of doing this. Okay? You've probably been taught some of them. I guarantee you that some of you have been taught ways that are really confusing. This is not confusing. I don't care how you do acid-base as long as you have a system that works for you and works every time. This is 1, okay? So, step 1, what is the pH? Well, if it's less than 7.4, it's an acidemia, and if it's greater than 7.4, it's an alkalemia. Step 2, what's the primary disorder? The way you do this is you ask yourself, what direction did the PaCO2 go? And what direction did the bicarb go? And which one of those explains my pH? For example, in a respiratory acidosis, an increase in the PaCO2, because CO2 is an acid, will cause an acidemia. In a metabolic acidosis, a decrease in the bicarb, because bicarb's a base, is going to cause an acidemia, right? Less base, acidemia. So let's look at this pH of 6.9 on the left. Is that an acidemia or an alkalemia? It's an acidemia. Now your PaCO2, what's normal? 40. It's 90. Which way did that go? So there's like more CO2, and CO2 is an acid or a base? There's more acid. So would that have explained your pH of 6.9? Yeah. More acid, acidemia. Which way did your bicarb go? Did it go up or down? Up. Bicarb's what? An acid or a base? You have more base. Could the change in bicarb have explained your pH? No, because bicarb's a base and you have more of it, and you know you have an acidemia. You can't get an acidemia by adding more base. So the change in PaCO2 going up explains the change in pH. This is a primary respiratory acidosis. Okay, this is key. Does that make sense? Okay. Okay, let's look at the one on the right. pH of 6.9. What do we call that? Acidemia. Which way did the CO2 go? Down. Would that have caused an acidemia? No. This isn't a primary metabolic process. Which way did the bicarb go? Down. Would that have caused? So it's a primary metabolic acidosis. Makes sense? Let's try again. 7.6. What do we call that? Alkalemia. Which way did the PaCO2 go? Could that have caused the alkalemia? Which way did the bicarb go? Would that have caused the alkalemia? No. Okay. So this is a primary what? Respiratory alkalosis. How about the other one? What's that? Alkalemia. What's the primary disorder? Primary metabolic alkalosis. You got that? That's how you do it. Okay. Clinical pearl. The PaCO2 and the bicarb should always be going in the same direction because of the compensatory relationship between the two of them. If they do not go in the same direction, there is trouble in paradise, and you can guarantee that there is at least a double acid-base disorder. Okay? Does that make sense? Because if you don't understand that, all the rest of it will be worse. Okay, good. Step 3. So step 1 was? What's the pH? Step 2 is? What's the primary disorder? Step 3 is what's the gap? Okay? That's the formula for gap. Sodium minus the sum of chloride plus the bicarbonate. The theoretical normal is in the range of 8 to 14. We're going to use the practical normal. Clinical pearl. Okay? When you do math, you should use the serum bicarb from the chemistries and not the bicarb from the ABG. Why? Calculated. The ABG is a calculated value, the bicarb. The serum bicarb from the chemistries is measured. So use that one. You will notice that they often are not the same. They're not really far off, but they are often not the same. Okay, so why do we care about this? We care about this for 2 reasons. If you know what the gap is, number 1, you will be able to recognize some subtle findings that are, quote, hidden in the chemistries that you might not otherwise notice. Like, your patient looks fine, but you calculate the anion gap and it's 30. They're not fine. There's trouble. But you might not notice it if you don't do the math. Number two, it will allow you to classify what kind of metabolic acidosis a patient has and glean some very useful clinical information, okay? Okay, so what the heck is this? It is the gap between unmeasured anions and cations. Because of the principle of electroneutrality, we like to have equal numbers of positives and negatives, okay? Turns out that sodium, which we measure, makes up 90% of cations. Chloride and bicarbonate make up about 85%. The difference between those two constitutes the anion gap. Now, if we measured every single anion and every single cation, the anion gap should be 0. But we don't do that. We only really measure the sodium and the chloride and the bicarbonate, okay? So the difference between those two is the anion gap. There are a lot of unmeasured cations and unmeasured anions out there, but a big part of unmeasured anions are the anions that come from the liberation from acidic compounds. So when you have an unmeasured anion that comes from an acidic compound, it lowers the bicarb. When the bicarb goes down, because bicarb is part of the math equation, your anion gap goes up, okay? Short story, when you have an elevated anion gap, it is usually an anion that came from an acid, okay? Okay. It's useful for diagnostic purposes to subdivide your acidoses into gap and non-gap, okay? In all acidoses, the bicarb is low, okay? In some, okay, when the anion gap is normal, the chloride has to be high. And so another name for anion gap, for non-anion gap metabolic acidoses is hyperchloremic metabolic acidosis. I suggest you don't use that term because it's confusing. I suggest you just use, it's a non-gap metabolic acidosis, but I want you to know that they're technically synonymous. Okay? So, give me the mnemonic for anion gap metabolic acidosis. Okay. Couple things. So, methanol, uremia, DKA. What's AKA stand for? Alcoholic ketoacidosis. And what does SKA stand for? Starvation. Lump them together. They don't have a cute little place in the mud piles mnemonic, so put them there. The P stands for propylene glycol and fenformin. Okay? Rare. The I stands for what you see there. Please, it doesn't include isopropyl alcohol. We'll get there later. L for lactic acidosis. E for ethylene glycol, not ethanol. Being drunk does not give you a metabolic anion gap acidosis unless you've been drinking so much that you're not eating, and then you have a ketoacidosis because you have a starvation ketoacidosis. Or you get so dehydrated that you make lactate and you have a lactic acidosis. But good old-fashioned ethanol isn't going to do it. Okay? And the S stands for salicylates and solvents. Give me a cute one for non-gap metabolic acidoses. Yeah, there's a bunch, but here's one, hard-ups, okay? The big ones here are diarrhea, RTA, and if somebody's on a carbonic anhydrase inhibitor like acetazolamide or dorzolamide, okay? Spironolactone 2, okay? Step 4, the delta-delta, okay? Who's heard of this? Okay, so a bunch of people have not heard of this. Okay. What does the delta-delta actually do for us? It provides information about concurrent metabolic processes. It tells you nothing about respiratory processes. It only tells you about concurrent metabolic processes. It can tell you about anion gap metabolic acidoses, non-gap metabolic acidoses, or metabolic alk. The actual explanation for how this works, it will take me like at least 10 minutes to go through, okay? But a cute way of thinking about this, which is not necessarily 100% accurate, but it works, is that it actually can help you calculate what the bicarb would be if that primary disorder wasn't around. And another way of saying that is it allows you to know if there's a metabolic acidosis or alkalosis also in existence here, okay? So, we'll get back to this, and it'll make more sense in a minute. But here's the formula that I suggest you use. You take the observed gap, and you subtract what normal gap would be, and you add it to the bicarb. So if we're using 10 for what a normal gap is. You take the gap that you calculate, you subtract 10 from it, and you add it to the bicarb. And the way to think about this is, what is a normal bicarb? 24. So if you do the delta-delta math, and you get a delta-delta that's greater than 24, okay, that tells you that there's a concurrent metabolic alk. Because my soft explanation for what the delta-delta is it tells you what the bicarb would be if the primary disorder wasn't there. Okay? So if you have a bicarb greater than 24, that's a metabolic alkalosis. If you have a bicarb less than 24, that's a metabolic acidosis. Okay? Now, go ahead. No, always calculate the delta-delta for every single patient, no matter what their primary disorder is. Always. Because what this will do is it may tell you about a newly identified metabolic alk if you didn't know about it yet. Okay? And it may be the only way you would figure that out. Also, if you know that there's a metabolic acidosis, it may tell you that you've got a gap acidosis. It may tell you that you've got a non-gap. Or if you know that you've got a gap, it may tell you that you've got a non-gap. This will make more sense when we do practice questions. Okay. There's another way to do this. It involves a ratio. I don't like this way. I think it's confusing, but it exists. This is more commonly taught than the way that I just showed you, but the way that I just showed you is a little easier to do. Okay. Step 5 is the compensation accurate. There are 6 formulas, okay? You can look them up. Only memorize one of them. Memorize the formula for the compensation for a primary metabolic acidosis, which is the Winters formula. Look the rest up. Here's the Winters formula. It's 1.5 times the bicarb, plus 8, plus or minus 2. And this tells you what the PaCO2 should be. And you can compare that to what the PaCO2 is and figure out how the compensation is doing. Again, use the chemistry's bicarb and not the ABG bicarb. Okay. Now, when you do the Winters formula, it's going to tell you what the expected PaCO2 is. If the patient's PaCO2 is higher, okay, they've got more acid than they should. That means they have a concurrent respiratory acidosis. If the patient's PaCO2 is lower, that means they have less acid than they should, which means they have a concurrent respiratory alkalosis. Okay? Making sense so far? Okay. That's the formula for metabolic alk. That's the formula for acute respiratory acidosis, chronic respiratory acidosis, acute respiratory alk, chronic respiratory alk. Look them up. It's not that common. Step 6 is why. The clinical presentation will always provide clues to the underlying acid-base disturbance, even in a triple. This will become clear when we do some examples, and this is the crucial step. Otherwise, you spun your wheels and you didn't really learn anything useful. So in summary, that's the money slide again. What's the pH? What's the primary process? What's the gap? What's the delta-delta? Is the compensation adequate, and why? Good. Half an hour. So we got a half an hour to practice. So will someone read the case out loud for me? Anybody? Bueller. Go ahead.
An 18-year-old female with no previous medical history and family history of diabetes presents to the ED with 3 days of rhinorrhea, dry cough, subjective fever, chills, myalgia, 24 hours of increasing generalized weakness, nausea, vomiting, and 4 hours of shortness of breath. She's now lethargic and ill-appearing. Temperature 101.4, pulse 160, respiratory rate 34, BP 68/54, OT sat is 80% on room air. She's lethargic, dry mucous membranes.
Left lower lobe.
Right lower lung, right upper lung crackles, delayed capillary breathing.
Okay, so clinically, what's happening in this case? What's the primary diagnosis based on your history and physical exam? Let me give you a hint. Does this person have an infection? What kind of infection? She's pneumonia, okay? Is it unilobar or multilobar? Okay. Does she meet diagnostic criteria for sepsis? Does she meet diagnostic criteria for severe sepsis? Yeah. We don't know if she's in shock yet because the technical definition is non-fluid responsiveness, okay? But, okay. Here's some labs. You don't need to read them out loud, but what strikes you? Huh? Yeah, we've got a bit of a pH problem here, don't we? How's the glucose? It's kind of high, right? Okay. And I didn't calculate the gap for you because that's step 3. So we're gonna look at this. Step 1, what's the pH? So what do we call that? We call that an acidemia. Step 2, what's the primary disorder? Which way did the bicarb go? Could that have caused the acidemia? Yes. Which way did the PaCO2 go? It went down. Could that have caused the acidemia? No. So what's the primary disorder? Primary metabolic acidosis. When you're with patients, you write this down. Acidemia. Next line. Primary metabolic acidosis. What's step 3? What's the anion gap? Okay. So by applying advanced mathematical techniques, what is the anion gap? 36. Okay. What's normal? So this is a primary metabolic anion gap acidosis. So now we've learned something. We know that there's a primary metabolic acidosis that's anion gap. What's step 4? What's the delta-delta? So the formula for the delta-delta is the observed gap minus expected plus the serum bicarb. So the anion gap that we got is 36. We're going to subtract 10 from that. That would be 26. Plus 4 would be 30. So we've calculated a delta-delta of 30, and we know a normal delta-delta is what? 24. So, and the delta-delta tells us what this patient's bicarb would be if they didn't have the primary disorder. So is 30 a normal bicarb? No. Is it too much or too little bicarb? Too much. And bicarb's a base or an acid? Too much base. So what have we just learned about this? This patient has a concurrent metabolic alkalosis. Did we know that before? Delta-delta is cool. Okay? We didn't know that, now we do. What's the next step? Is the compensation adequate? This is the one formula we memorize. The formula to calculate the respiratory compensation for a metabolic acidosis is called the Winter's formula. And the Winter's formula is, you've got to memorize it, 1.5 times the bicarb plus 8 plus or minus 2. Okay. So when you do the math on this, you get 14 plus or minus 2. So the expected PaCO2 is 12 to 16. Okay? And this person's PaCO2 is 34. Okay? So she should be blowing her PaCO2 down to 12 to 16. And she ain't. Okay? So she has too much or too little PaCO2? She's got too much. CO2 is an acid or a base. Hence, we have a concurrent respiratory acidosis. Triple acid-base disorder, how long did that take us? Maybe 2 minutes. We'll see if we can get faster. What's the last step? Okay. So we know she's got a primary anion gap metabolic acidosis, a concurrent metabolic alk, and a concurrent respiratory acidosis. Why? Here's a review. She's 16. She's had 3 days of runny nose, dry cough, fever, chills, and myalgia. Then 24 hours of increasing weakness, nausea, vomiting. 4 hours of shortness of breath. She's lethargic and ill-appearing. She's got a low blood pressure, a low O2 sat. Okay? She's got a high glucose. So let's take it step by step. She has an anion gap metabolic acidosis. Did she drink methanol? Is she uremic? A little bit, right? BUN 39, creatinine 2.1, so okay, a little bit. Does she have DKA, AKA, SKA? Well, we could measure her ketones, but I would say probably, okay. What's next? MUDP, paraldehyde fenformin, isoniazid, isopropyl alcohol. L? Yeah, she's got that. Salicylates solvents. Okay. So we think she's got a combination of DKA, lactic acidosis, and uremic acidosis. Why does this person have a metabolic alkalosis? Okay, A, she's vomiting. B, what's her volume status? It's low. And when the kidney retains fluid, it will retain bicarb. That's a very fast explanation, but that happens. That's called a contraction alkalosis. Okay? And why does this person have a concurrent respiratory acidosis? She's multilobar pneumonia. That is why this person's pH is horrible. Okay? This is very dangerous. Okay? All right. So, you feeling good? Should we do another one? All right. Case 2. Somebody else read this out. Quickly, because we got to get through 4 more. Okay, what's really weird about the labs? The K is bad, the bicarb is bad, and then we've got a lipase that's pretty up there. Clinically, what's going on here? Okay, so probably pancreatitis, right? She should have epigastric tenderness before we say that, but it's pretty likely. Do you get tea-colored urine and clay-colored stools from good old-fashioned, regular old pancreatitis, nothing else going on? Huh? Yeah, gallstone pancreatitis, choledocholithiasis. Okay, good. So, step 1, what's the pH? Alkalemia, good. What's the primary disorder? Which way did the CO2 go? Up. Is that the primary? No. Which way did the bicarb go? Up. Is that the primary? So what's the primary disorder? Primary metabolic alkalosis. Step 3, what's the gap? 8. Okay? So it's certainly not a high gap. It's a little bit low. So we're going to note that. Okay? We're just going to remember there wasn't a very high anion gap. What's the next step? The delta-delta. Okay? So we take the 8 and we subtract 10 from it. I know it's scary because that's a negative number. It's very scary. It's -2, and we add that to the bicarb, and that's 38, and we get 36. So the delta-delta is 36. When you have a delta-delta greater than 4, that tells you have a concurrent metabolic alk. But we already know that. So this didn't give us new information, but it confirmed what we already knew. Is the compensation adequate? Well, that's the formula, okay? The PaCO2 should increase by 0.6 for every 1 increase in bicarb. The bicarb went up 14. So if we take 14 and we multiply it by 0.6, you get 8. The PaCO2 should be 40 plus 8, which it is. Okay, so the compensation is adequate. So we have a simple case here. This person has a metabolic alk. Okay? Why? Why does this person have a metabolic alk? Yeah, because she's vomiting her guts out. And what's her volume status probably? Yeah, okay? So this is choledocholithiasis with gallstone pancreatitis, and she has a primary metabolic alkalosis by vomiting and volume contraction. In this case, the ABG analysis told us that this person is compensating appropriately and there's no other disorder. So we can just be simple and address her metabolic alk and treat it appropriately. Case 3, another volunteer.
25-year-old male with significant past medical history, bipolar disorder, presents to the ED comatose after family found him unresponsive in the garage. Vomiting per EMS and vomiting in the ED. Appears volume depleted. Juice crackles and hypoxia in the radar.
So let's look at the chemistries first. Anything psycho on the chemistries? Yeah, actually that's a misprint. It shouldn't be 8.4. But yes, good eye. That's a problem, okay? All right. And then we've got the ABG analysis, okay? So step 1, what's the pH? What do we call this? Acidemia. Step 2, what's the primary disorder? Okay, so we've got a... So this is interesting, okay? both changes could explain this, and this is why I gave you this case, because we're refining now. Because the PaCO2 went up, that could explain it, and the bicarb went down, that could explain it. So now we have a case where the PaCO2 and the bicarb are going in opposite directions, and I told you that it shouldn't happen. And if it does, there's trouble in paradise. So we know that there's at least two disorders going on here, but we're left with the question of what's the primary disorder. So here's the rule, okay? Both changed by 6, right? But there's a greater proportionate change in the bicarb because the bicarb normal is 24 and the PaCO2 normal is 40. So 6 out of 24 is a much greater proportionate change than 6 out of 40. So we're going to go and we're going to say that this is a primary metabolic acidosis. And when you get things changing in opposite directions and both could explain it, the way you pick the primary disorder is which changed to a greater proportion. Make sense? Okay. That will happen rarely, but when it does, I don't want you to be confused. What's the gap? 20. The gap is 20. How did I do that? I applied advanced mathematical analysis, okay? So we know that this is an anion gap metabolic acidosis. What's the delta-delta? Okay, 20 minus 10 is 10, plus the 20 is 30. So what does this tell us? There's a concurrent metabolic alk. Is the compensation adequate? What formula do we use? Winters, okay? And when you use Winters, the expected, that should say PaCO2, okay, should be 36 to 40. And what is it? It's 46. Okay? So what did we just learn? Okay, very good. There's a concurrent respiratory acidosis. Triple, how long did that take? Are we down to about a minute? Because we got to get you to 30 seconds. Okay. So the last step is why. So why does this person have a metabolic anion gap acidosis? Because he what? Okay. So you think he drank antifreeze just because we found him in the garage? Oh! There were calcium oxalate crystals. Okay. Okay. Do we want any other data? Or are we just so smart that we know it? Or do we want to be thorough? What other data do we want? I mean, should we check a lactate? Should we check ketones? Is there anything else we should measure? Say that again? Medication history, okay. Is there a way for you to have a better idea of whether or not he did drink ethylene glycol? Huh? Yes, thank you. We want to measure this guy's serum osmolality, and when we do, it's 340. Okay, so what the heck? We want to do that because we want to measure the osmolar gap. Okay, serum osmolality should be somewhere between 285 and 295. You can calculate it or you can measure it. If you calculate it, you multiply the sodium times 2. You divide the glucose by 18, the BUN by 2.8, and the blood alcohol level by 5, and you add all that stuff up, okay? And if you compare the calculated osmolality with the measured osmolality, they shouldn't vary by more than 10 to 15. And if they do, there's something else happening besides glucose, sodium, BUN, and alcohol, okay? Something else is explaining that gap. Now, lots of things can do it, but 4 things that you need to know can cause an elevated osmolar gap are methanol, ethylene glycol, isopropanol, and ketones. Memorize, okay? Interestingly enough, methanol, ethylene glycol, propylene glycol, and ketoacidosis will cause an anion gap acidosis with an elevated osmolar gap. But isopropanol will only elevate the osmolar gap. It will not cause an anion gap. Just for you to know. Okay? So here's your toxic alcohols. Okay? Rubbing alcohol is the isopropyl alcohol. Antifreeze is the ethylene glycol. And sterno, okay, is got methanol in it. Okay. So if you do the math on this guy, his calculated osmolarity is 286 and his measured is 340. That's a gap of 54. You shouldn't have a gap that's more than 10 to 15. You've got an osmolar gap in a dude who was found in the garage, and he has calcium oxalate crystals in his urine, and calcium oxalate crystals are a byproduct of ethylene glycol metabolism. Okay? So why ethylene glycol? Why is this guy, I just gave you the answer. Why does he have a concurrent metabolic alk? Well, because he's been vomiting a lot. And he's probably volume deplete. Why does this person have a concurrent respiratory acidosis? Diffuse crackles and hypoxia. So we've got a respiratory issue. Maybe this is an aspiration pneumonitis. Ethylene glycol gets you good and drunk. Probably wasn't protecting his airway when he started to vomit. Okay, just a couple caveats. You should know that because of the metabolic pathways of the toxic alcohols, there will be times where if you do the analysis early, in the middle stages, or late, the gap is going to be going in one direction, the anion gap, and the osmolar gap will be going in another direction. And so unless you get it at a point where both are elevated, one can be higher than you might expect and the other can be lower. So just be a little bit careful. The minute you drink ethylene glycol, you didn't metabolize it yet. Okay? So you'll have an osmolar gap because it'll be measured, but you won't necessarily have a high anion gap. But as time goes on and you start to metabolize it, your osmolar gap may be going down and your anion gap may be going up. So just beware. Okay, how are we doing? Are we still alive? Case 4.
A 68-year-old smoker was never seen a physician, was brought to the ED, severe respiratory distress. This lethargic or false command, he has poor air movement, prolonged expiratory phase, diffuse wheezing and tympanic to percussion. Chest X-ray shows hyperinflation, flattened diaphragm, and new left lower lobe and left upper lobe infiltrates. His family says he was at his baseline last week, which includes a chronic daily cough and dyspnea on exertion. For the past 5 days, he has had increasing generalized weakness, dyspnea, cough, and hasn't been eating or drinking anything. He looks extremely dehydrated today.
Okay, then you've got some vitals here. We have some trouble in the vitals, okay? So we're just going to kind of look at that stuff, and what do you think is going on?
You say tympanic to percussion, that's chest?
Yeah,
Chest, not abdomen.
not belly. So what's your clinical impression? What's the primary diagnosis here? Okay, so this person probably has undiagnosed COPD. Say that again? Yeah. Yeah, so this is probably an acute exacerbation of COPD secondary to pneumonia. And does this person meet diagnostic criteria for sepsis? How about severe sepsis? Yeah, he's got evidence of end organ damage because he is lethargic. And he's got a lactate. Yeah, there's a lot of reasons, okay? Okay, so we're going to do the analysis. What's the pH? Acidemia. What's the primary disorder? Yes, this is a primary respiratory acidosis. What's the gap? $26. Okay, so this is interesting now. We know that this person has a primary respiratory acidosis. But now we know that this gentleman also has a pretty high anion gap. And the pearl I'm going to tell you is that if somebody has a gap greater than 20, it is very likely that they also have a concurrent metabolic acidosis. So we're going to note that. He's likely to have a metabolic acidosis. So the gap just told us something that we wouldn't necessarily have known otherwise. Okay? What's the delta-delta? So, oops, 26 minus 10, blah, blah, blah. All right, 40. Delta-delta of 40 tells us that there's a concurrent metabolic alk. So now, from the gap, we learned that he probably has an anion gap metabolic acidosis. And from the delta-delta, we learned that he probably also has a concurrent metabolic alk. Two things that you would definitely not have known otherwise. or you probably wouldn't have known otherwise. I mean, you could look at the clinical and assume, okay? Is the compensation adequate? So for here, okay, this is probably a process that he's had COPD for a long time, and then he got sick over a number of days. So we're going to use the formula for chronic compensation, okay? And so the bicarb should increase by 3.5 for every 10 increase in PaCO2, okay? And what you get is the PaCO2 went up from 40 to 70, all right? So that's 3 times 3.5, which gives you 10.5. The expected bicarb should be 40.5, and what is it? It's 24. So does this person have enough bicarb? So what do you know now? He has a concurrent metabolic acidosis. Now, that's what the gap implied, and now we just confirmed it. And we know it's a gap because he had a gap. So this is cutesy, isn't it? All right, so now why? So why does this person have a primary respiratory acidosis? Because of his acute exacerbation of COPD that's decompensated and he has pneumonia, okay? Why does this person have a concurrent anion gap metabolic acidosis? Say that again? Okay, so he has a lactic acidosis, and part of that is because he's hypoxic, but that's not the only reason he has a lactic acidosis. Perhaps. This guy's he's got a blood pressure of 90 over 54. So yeah, not only is he probably hypoxic, but he's not perfusing the tissues with enough blood. Okay? So there's definitely lactic acidosis. Okay? Why does he have a concurrent metabolic ALK? As every other patient had so far today, he's volume contracted. Okay? It certainly can, yeah. Yes, Lasix can cause an overdiuresis and precipitate a metabolic ALK. Okay, so case 5, last case. Okay, who wants to read this one? Okay, so I want you to take a look at these labs. Is there anything incredible on here? Yeah, other than the chloride and the strong positive serum ketones, I mean, look at the ABG. I mean, what do you think of that? So we're done. End of lecture. Right? No. Okay. It's a pretty benign looking ABG, okay? So now, we're going to go through because we're thorough, okay? Number 1, what's the pH? Remember I told you, don't use ranges. So if we say 7.4 is normal, what's this pH? It's near normal, but we're going to call it an acidemia. And it's slight, and we're going to note that, okay? It's not impressive, but technically, it's on the acidemic side of the continuum. So what's the primary disorder here? They're near normal, okay? But technically, which way did the PaCO2 go? Down. Would that give somebody an acidemia? No. Which way did the bicarb go? Down. Would that give someone an acidemia? So we're going to call this a primary metabolic acidosis, and we're going to remember that it's small, okay? Now, what's the gap? I know, this is a hard thing. All right, it's 27. Is that a normal gap? That's pretty up there. I'm starting to think maybe there's something to learn from this. Okay, so we know that his acidemia is from a metabolic anion gap acidosis. Okay, what's the next step? The delta-delta. What's the delta-delta? 27 minus 10. 17 plus 21. 38. What does that tell us? there's a concurrent metabolic ALK. So now this patient with a pretty benign looking set of labs, a near normal pH, and a pretty normal PaCO2 and bicarb has a double acid base disorder. Okay? Is the compensation adequate? Well, we're going to apply our friend, the Winters formula, and it will tell us that we have an expected PaCO2 between 38 and 42, and his is 37. Okay? So if we're going to split hairs, this person has a concurrent respiratory alkalosis because he's blowing more CO2 off than he should. So this person has a triple acid base disorder, and everything looked pretty benign. So this is a reason why to do this stuff. Okay? So why? Why does this person have a metabolic anion gap acidosis? So this is probably alcoholic ketoacidosis, starvation ketoacidosis. We don't know what he's getting clean from. Okay? It could be alcohol and whatever. He may not be eating enough. Okay? Why does this person have a concurrent metabolic ALK? Because he's vomiting and he's dehydrated. And why does this person probably have a small but evident concurrent respiratory ALK? Good. Okay. One caveat. You could also say that he has inappropriate respiratory compensation. I suggest you don't do that, because inappropriate respiratory compensation could mean it's too much or it could mean it's too little. So it's more specific for you to say he has a concurrent respiratory alkalosis. You could say his compensation is inadequate and he has a concurrent respiratory ALK. Okay? All right. Or his compensation is inappropriate. But it's more specific for you to actually name what it is. Okay. So we're almost done here. A couple things to note. If you have a patient who is severely hypoalbuminemic, you need to bear in mind that you should correct what the calculated anion gap is. And just, you can look this up. You don't need to memorize it. But basically, for every 1 below 4, you need to add 2.5 to what your calculated gap is, which means that if you're getting a gap of like 14, 16, 18, but your patient's albumin is 1.5, that gap is much more significant than you might otherwise appreciate. There has been some controversy in the literature over whether or not you need to correct the gap, but most authorities will recommend that you do. Okay? So just something to know. Number 2, it is possible to have an increased anion gap without an acidosis, okay? But when your gap starts to go above 20, it's very likely that this is from a metabolic acidosis and not from one of these other things. But you should just be aware that gaps less than 20 could be from things other than a metabolic acidosis. Also, you can have low gap, and some cute things to remember about causes of low gap are that you can have unmeasured cations like paraproteins, so in multiple myeloma, okay? You can have a low gap, just something to look for. And also with issues of lithium, okay? Okay, there are some references, and I wanted to leave negative 30 seconds for questions. I know that was a lot of material. Say that again? I can email this to Rich, and he can email it to all of you. So take home, Dr. Antonicchia.
As he said earlier, you can have a lot of systems by which you can analyze this, and as long as you're consistent, that's fine. But one of the reasons why the way Dr. Corby just kind of taught you in a very systematic way and a very quick way to get through this is going to become very important to you when you take your board examinations. And so the residents here are going to take boards in internal medicine, because you can guarantee that you're going to get 4 or 5 acid-based questions on the board at least. And you're going to have to tickle them out, because, and we'll talk more about finding out what you have to answer in a question, because sometimes you get a whole load of data and you'll find that you'll think you're going to about an ethical issue on the case. You got to know what they're going to ask you. When you go back to the question, you'll want to highlight. Once you get to that, you should always look at the question they're asking you before you read the whole question, because you're going to select out information that you need. So if you look at it and it does ask you for what is the acid-base disorder, now you know what to go back to and highlight as you're going through that question, and to give you all the information you need to go through these 6 steps to get it. And the point I'm driving at is that during your boards,